My screen is visible?
Yes, sir.
Is it moving?
Yes, sir.
Okay, so we'll start the session today. It's about approach to bleeding child. So, how much frequently you people are encountering a bleeding child? It could be simple or a massive bleeding. So how much frequently your people are seeing a child with bleeding? Reason could be anything. I'm not worried about the reason. So how frequent you people are encountering? Is there any answers for this? That it is frequent, at least monthly twice or twice you're seeing a bleeding child, or it's very rare, you're not at all seeing them, even yearly once also people are not encountering a bleeding child. I'm not talking about a massive bleeding needing resuscitation. I'm talking about trivial bleeding only.
So in my clinical practice, I have seen a nasal bleeding more frequently in childs.
Okay.
And sometimes vomiting with mixed with blood. This much, and they are responding very soon with a simple conservative management.
Good. So at any point of time, you thought that this bleeding is not a simple bleeding, and I am dealing, say, this could be in any bleeding related pathology or pathological bleeding.
So I investigated coagulation profile and those all things, no history of liver disease and no any ecchymosis or subcutaneous bleedings. So mostly it's a local pathology, sir, not systemic pathology I found.
Okay, so you found it is a local pathology. So any example for local pathology?
Like mucosal bleeding because of dryness, or sometimes nasal prick, nasal picking like in children's. So maybe these are the cause of rhinosinusitis, maybe some bleed in the nose in the time of rhinitis. And during vomiting, miliary tear in esophagus, that may be the reason for the hematemesis.
So good. Exactly. So you are telling that these are not mostly, these are primarily local pathology related. Okay, so with this background, just we'll move on. So my question here now is, what is primary hemostasis and secondary hemostasis? Without this, we cannot move on to this topic. What is primary hemostasis? The answer is in front of you, just you have to read to me.
The primary platelet plug formation at the site of injury.
So it is a primary hemostasis is up to platelet plug formation. Secondary hemostasis is what extra addition to that? What extra you're adding to that for the primary platelet plug? So you're adding
Fibrin clot.
So fibrin, and it's going to make the clot very strong. So that stops the bleeding completely, and from there you will have reepithelialization. So with this, for primary hemostasis, what the main things is going to happen is that the local vasoconstriction, then comes the platelets, they come and others to the exposed collagen. So they need to others there, and they get activated, and which is getting activated, they form a plug. And also not only forming plug, they release some clotting factors as well. And for this, mainly for platelet adhesion, we need one more molecule here, that is von Willebrand factor. So these are the two important things which will participate in primary hemostasis. One is the platelet, second thing is von Willebrand factor. So platelet adhesion followed by activation, then aggregation, and forming a plug, and later on releasing clotting factors. Up to this stage, we'll deal with primary hemostasis. So any problem with this will be represented in the disorder of primary hemostasis. And once the clotting factors are released and they got activated, and finally everything lead to activation of thrombin. Once thrombin is activated, it will clear the fibrinogen to fibrin, and then the fibrin will be deposited in the formed platelet plug, and it will strengthen the clot.
14, 16 ఏమో ఉన్నాయా బాబు రెగ్యులర్ యూటీలో వస్తుంది.
You have
రిపీట్ వచ్చారు
పర్ణిక
secondary.
మిమ్మల్ని అడిగి అల్ట్రాసౌండ్ చేయించుకుంటామని చెప్పారు. నార్మల్ అన్నది
కల్చర్ నార్మల్ గానే ఉంది. యూరిన్ ఈరోజు చూస్తే 3 to 4.
Just give me 1 minute.
స్కాన్ వెళ్ళామా
స్కాన్
So the pathway for secondary hemostasis is the coagulation cascade. It includes 3 pathways. One is intrinsic, extrinsic, and a common pathway. The extrinsic will be started by a tissue factor which stimulates the factor 7, then which will activate the factor 10. An intrinsic pathway starts with factor 12, consequently it activates 9, 11, 9, and 8. Finally, it will combining with the 9 activate 10. So from 10, it starts the common pathway along with factor 5. 10 cleaves the prothrombin to thrombin, and thrombin finally cleaves the fibrinogen to fibrin, which will forms the clot. So we need to identify which pathway defect is there, and based on the investigations and clinical features. So extrinsic is mainly factor 7. Intrinsic is all other factors. Common, you need have a defect in 10, 5, and thrombin and fibrin. So coming to approach, so like we previously discussed, the mild bleeding and bruising are common in general population. So like children will have epistaxis, like the previously are told, it because of a nasal picking, dryness, rhinosinusitis, and trauma-induced bruising. And these are the common things in general population. So we are not much worried about that kind of bleeding in the population. So the main thing when a child presents significant bleeding or bruising. So mild bleeds, we are not going to much worry. With significant bleeding and bruising, you need to have 3 differential diagnoses. Whether it's a physiological or accidental bleeding. If you have an evidence of trauma which can explain the significant bruising, then you don't need to worry about if the injury is same as the impact. So other thing is non-accidental injuries. When they're telling some kind of injury, but that kind of injury is not matching with the bruises on the body, so you need to suspect non-accidental injuries. And the last thing what we are dealing with concern is, say, whether it is a bleeding diathesis. So sometimes they can have large bruises or a bleeding without any trauma. So then we need to suspect a bleeding diathesis in them. So with these 3 broad differential diagnoses, we need to have a goal to approach the child. So you should have a broad differential diagnosis. You cannot exclude anything at the starting. And you have to narrow the option by carefully taking the history. That includes your personal history, medical history, and family history, and with the physical examination findings. So with this, you need to narrow down your diagnosis. And you need to order your most appropriate laboratory test, so to reach the final diagnosis. So you cannot order a bunch of investigations to get a diagnosis. So you need to narrow down your problem. So which is the most likely diagnosis in this child, and you need to choose the investigations based on the probable diagnosis. So with this background, we move on to the case scenario. So this is a 1-year-old child, came with severe epistaxis since afternoon, and It was not getting controlled with routine measures. They tried nose pinching and all, but it's not getting controlled. And child was spitting out clots and has a lot of blood in vomiting also, maybe swallowed blood. So he was brought to ER around evening. By the time he came to ER, he vomited around 200 ml of blood clots mixed with gastric contents. So this is the scenario. A child was reached to the ER. So initial impression, child was lethargic. So there is increased work of breathing. Child had pale peripheries. What is the physiological status and what is the intervention to be done?
Hemorrhagic shock, in a state of hemorrhage.
What is the physiological status?
Unstable, life-threatening.
Unstable, life-threatening. So what do you want to do now? Yeah, what we have to do now is unstable, life-threatening condition.
ABCD management.
Before that, because we are not moved to primary impression, we are here only in the initial.
To start on oxygen to give a fluid bolus 10 ml per kg push.
I am not told in the BP yet. So you need to start an oxygen, get an IV access, and you need to quickly assess the primary assessment. That is what we can do here. So because of this, child had frequent epistaxis and vomiting, so we need to clear the oral water secretions are there. And you get IV access, get the samples here. So in primary assessment, child airway is maintainable with suction and positioning. Breathing wise, mild tachypnea was there, but not much retractions. Circulations wise, heart rate was high, pulses are low, peripherals are cold, CRT is 5 seconds, BP is low, and disability is okay, GRBS is okay, temperature is okay. So what is the problem here? Assessment, identifying assessment.
So child is in hypotensive shock, sir.
Okay.
Give a fast fluid bolus, sir, of 20 ml per kg, sir.
Reason for hypotensive shock?
So hypovolemia, sir. Maybe following blood loss, sir.
Complete it. Whenever you are telling shock, you complete the full. So it is hypovolemic shock and severity is hypotensive shock. So you want to give fast fluid bolus. Okay. Anything else? Anything else you want to do here? You can stop it here. Just to give fluid bolus. What is the reason for hypovolemia here?
Blood should be arranged as soon as possible.
Exactly. Never ever stop by giving fluid bolus and correcting vitals. That is not the aim we are doing for hemorrhagic shock. When you know the shock reason is blood loss, and if the blood loss is so much that it's causing shock, you cannot revive that child with fluid bolus. This is the first point everyone has to learn from this class. Just giving a fluid bolus or starting an inotrope or maintaining BP is not sufficient for hemorrhagic shock. The management of hemorrhagic shock is blood. It's not fluid. You cannot replace RBC blood with NSR albumin. So you need to give blood. No other go. If the child presents with shock with you, that means the child had lost so much blood. So that so much blood loss cannot be replaced just by replacing with the fluid. So you need to give blood. So meanwhile you're arranging for a blood, you can give fluid bolus to maintain the vitals, but that is not going to be enough. That's what everyone has to learn. Now, the moment the child walks to your ER with so much bleeding, the first thing you have to arrange is the blood. So meanwhile you can try fluid bolus. So don't forget this basic thing. So this child has respiratory distress, could be some aspiration, or could be some shock related metabolic acidosis. I don't know that. and hypotension is there, definitely hypovolemic shock is there, and child is lethargic because of most likely because of this hypotensive shock related secondary cerebral dysfunction. So that is what my primary assessment findings were. And the management, as you told, it's correct. And as you had to give push and pull, meanwhile arrange the blood. Don't forget arranging blood. Don't end. So just discussing only about shock, fluid. It's not fluid here, it is blood. So any child presenting significant bleeding, we need to try to minimize the bleeding. That is called hemorrhage control. So you cannot keep on giving blood for any child. So you need to try to control it as well. So that is what we discussed in polytrauma management as well. So when you're doing, when you're asking a shock child, you're correcting a shock, meanwhile, you need to try to take the measures to control the bleeding. Unless you control the bleeding, you cannot keep giving 10 packets, 20 packets of blood for any child. So one side resuscitation to be going on, other side you need to take the measures to control the bleeding. So this child is in epistaxis. So what we can do is we can pack the nas. So nasal packing can be done. So simple nasal packing. So we'll see later how nasal packing can be done. So you can, if you have ENT backup, you can ask for ENT people to come and have a look. So the other measure is because of bleeding was there. So you can try tranexamic acid as well. So these are the things we need to take care in an emergency room itself. It's not going to happen in the PICU. You need to start these things in the emergency room itself. So don't waste time there. So one side resuscitation, other side the bleeding control measures and arrange for the blood. So these all things has to go hand in hand. Many times the people will be stressed out there and they'll be thinking only of resuscitating a child, giving NS bolus, push. But meanwhile, you'll not arrange for the blood. Meanwhile, you don't do packing and child will be bleeding continuously. And how much fluid you're going to give, your blood vessel is not going to come up. So these three things has to go hand in hand. So shock management, arranging for emergency blood, not for 1 hour, 2 hours delay. So whatever blood is available, if not able to get the cross matching done, get O negative blood. So then arrange for the bleeding control measures like nasal packing and drugs. So these three has to go hand in hand. This is most important thing when you encounter a massive bleeding child. So in this child, after fluid bolus and blood transfusion, the shock was stabilized. The next question I got is whether I'm dealing with physiological bleeding or a pathological bleeding, or in pathological bleeding, whether I'm dealing with a bleeding diathesis. So how to answer this question? Is there any ways to answer this question? Okay, resuscitation part done. So I am not bothered about what is the cause for bleeding. So I done my resuscitation part. I stabilized the child. Now the shock is under control. And I did some nasal packing with that some amount of bleeding was controlled. So I have some time to discuss. So whether I'm dealing with a pathological bleeding or it is just a physiological bleeding. So how many of you agree with this pathological bleeding? Or still you are believing it is a physiological bleeding when you do monospeak or some rhinosinusitis?
It's a pathological.
So everyone think it's a pathological. How many of you agree it is a bleeding diathesis? It's a problem related to bleeding or it's simply some anatomical cause which is causing bleeding. Sometimes anatomical causes can also cause bleeding, this much profuse bleeding. So nasopharyngeal tumors, some tumors can cause this kind of bleeding. So at this point, the main DD is pathological bleeding, and it is not a physiological bleeding, definitely. No one is going to agree this is a physiological bleeding. In pathological bleeding, whether I am dealing with a local cause or I am dealing with a bleeding diathesis. Say, for example, a child with hematemesis is upper GA bleeding. So majority of this upper GA bleeding may not be due to bleeding diathesis. They will have local cause. So significant like ulcer-peptic ulcer bleeding, variceal bleeding. So they can be present like this only. So there, the percentage of pathological bleeding due to bleeding diathesis is very less. But in this child with epistaxis, the local cause is very less, which will cause discontinuation of bleeding. So here the percentage for bleeding diathesis is more. So when you have significant mucosal bleeding from maybe like nose. So depending on that, you need to evaluate what is the cause for pathological bleeding, whether it is an anatomical bleeding or it is simply a bleeding diathesis. So to answer these questions, we need to go. So epistaxis is a frequent presenting sign in bleeding diathesis. There is a study done in Philadelphia in a children's hospital in the ENT clinic. So they found that 11% simple bleed. I'm not talking about like child presenting like this. I'm telling like simple what previously discussed, epistaxis, which is getting resolved by itself. Even in that situation, 11% of children is found to have bleeding disorder, but they have recurrence. So the common cause they found was von Willebrand disease, platelet aggregation defect, and mild factor 7 deficiency. So this epistaxis can be due to local factors as well, right? Nasal mucosa, trauma, allergic rhinitis as well. So, but when you're dealing with recurrent, very younger age, so that is the risk factors for identifying bleeding disorder. And one more important thing is, at any point of time, child is needing an emergency medical care for epistaxis, that is pathological. So always think like this. If the child has just an episode of epistaxis in the home, it subsides by itself, it's very unlikely to be pathological. But the same child needing emergency medical care support, that is most likely it's pathological. So this is the bleeding questionnaire you need to keep in your practice. And if you have anything more than 2, so the 2 is consultation. So if any child coming to you for consultation of bleeding is not stopping, it could be epistaxis, it could be mild cutaneous bleeds, it could be gastrointestinal bleed, it could be anything. So any bleeding needing a consultation to you, so that signifies that there is a pathological bleeding. You need to evaluate. I'm not talking about it could be just only bleeding disorder. It could be any pathological anatomical bleeding as well. So please look into this. Any child requiring consultation is always pathological. So don't neglect them. So you need to at least examine locally, get an ENT opinion for epistaxis. So at least you can do. But if any child needing blood transfusion, any packing, nasal packing, that is definitely pathological, and you cannot send them without evaluation. You should admit them. So don't neglect any child needing blood transfusion. Any child needing blood transfusion for any bleeding, it is very significant. It determines the underlying bleeding diathesis, or it could be strong anatomical cause. You need to identify it. If you rule out anatomical cause, it's a bleeding diathesis, you have to evaluate it. You cannot simply ignore it. So what are features research to pathological bleeding in children is age related. So newborn with umbilical stump bleeding, intracranial hemorrhage, excessive bleeding following a heel prick or intramuscular injection. These are the common things we'll find out. Like when given a IM injection for a neonate, a vaccination. So and the child neonate has prolonged bleeding. So then you need to suspect, okay, there's something wrong with the bleeding. And any palpable or multiple bruises in infants and older children who are not independently mobile. So you need to suspect pathological bleeding. So persistent palpable bruising in an older child. So definitely you need to suspect pathological bleeding. And spontaneous bleeding in the absence of any anatomical causes. So you have to suspect pathological bleeding. These are the common things, age-related wise. And the personal history wise, recurrent mucocutaneous bleeding, especially if it's excessive spontaneous, like epistaxis is just occurring for a few seconds and it's controlled with pinching, and it is less than 3 to 4 episodes in any year, then it's fine. But if you have recurrence, so episodes more than 5 per year, and if it's excessive and the child needs to be visited in consultation for a pediatrician or ENT, then definitely it is a pathological bleeding. So atypical bleeds, whether they could be spontaneous or provoked, like hemostasis, very unlikely. Even if there's trauma, you can have a muscle bleed, but having hemostasis is very unlikely. And retroperitoneal bleeding, so where the trauma is going to hit the retroperitoneal organs is very less. So even with mild trauma or spontaneous bleeding in this kind of regions, you need to suspect atypical bleeds. And if you have excessive prolonged bleeding following hemostatic challenge, the commonest thing is dental procedures. So they'll complain that after removing their teeth, my child had prolonged bleeding. So until normally they'll be normal, but when you undergo or make them undergo a hemostatic challenge, like a trivial trauma, dental procedure or surgery, they'll be having excessive bleeding. So this kind of children, you need to catch them. They are pathological bleeding, and especially menorrhagia in adolescent girls. Don't neglect menorrhagia. That it's a puberty sign, and early puberty will have menorrhagia. But if any child coming to you menorrhagia with requiring blood transfusion, then definitely need to think of pathological bleeding. Don't neglect menorrhagia. Don't take off menorrhagia as just a physiological menorrhagia. So always do pathological, then tell them it's physiological. And traumatic bleeding is out of proportion or it gets reported injury. So this is the commonest thing. Sometimes we neglect this traumatic bleeding. So okay, child had trauma, that's why child had. If you have a very much big bruise, to the extent of the trivial trauma, so you need to think of that it's not correlating clinically as well. So it should be pathological bleeding. And if you have family history of recurrent bleeding symptoms and known diet bleeding disorder in a family and excessive prolonged bleeding during trauma or invasive procedures in a family members, it's very important. So this tells us some ongoing familial bleeding disorder. And physical findings, if you have multiple bleeding stigmata, so like that you have epistaxis, bruises, and petechia. So then you need to think of that it's not simply physiological, it should be pathological. And if you have physical findings like petechia, you should be platelet disorder. Even if you have normal platelet count, if you have petechia, you need to think of platelet functional disorders. And if you have jaundice or suspect liver disease related coagulation abnormality, if you have hypermobility and you need to think of vascular malformations. It's like Ehlers-Danlos syndrome, they can have vascular malformations, so they can bleed. And think of if you have musculoskeletal abnormalities like Marfan's and Ehlers-Danlos, you need to think of vascular malformations related bleeds. So I hope I'm clear. So in these three headings, you need to discuss about whether it is a pathological bleeding in children or not. So age-related bleeding. Second thing is history, which is like recurrent mucocutaneous bleeding, atypical bleeds, excessive prolonged bleeding, menorrhagia, and the bleeding is out of proportion to the reported injury. So these are the main things which we'll have to suspect. We are not dealing with the physiological bleeding. Then an examination. Okay, so this child all agree that we are dealing with a bleeding disorder. Okay, the next question what you have to ask is whether it's a congenital or acquired bleeding disorder. So how to know this? Come on. We have to move.
Age at presentation, sir.
Exactly. So age of presentation, anything else? So younger the age, it's most likely congenital.
History, sir. Family history, if it's
Family
having or
history.
not.
Yeah, most likely family history, the rest of congenital. Yeah. So with this, so mainly if the presentation is newborn period and infancy, most likely it's congenital. I cannot rule out acquired also. Like if you say neonatal cholestasis, it can be acquired cause as well, which is causing the bleeding. So most likely if presentation is newborn period and infancy, it's mostly congenital. And presentation later in childhood, it's most likely acquired problem, but minor congenital bleeding disorder cannot be ruled out. Sometimes we are seeing hemophilia children presenting very late. There they could be, it's not like severe hemophilia, they could have moderate to mild hemophilia. And family history is very critical in this kind of presentations. If they have X-linked inheritance, like all males are getting affected in the family, then it's high likely hemophilia. And if you have an autosomal dominant inheritance in the family, then it could be a von Willebrand disease or platelet functional disorders. So family history is very important in evaluating bleeding disorders. So don't forget about this family history. It's okay. Now we are agreed that we are dealing with a bleeding disorder and this is an infant child. So we are dealing with what you are dealing with infant.
Mostly congenital.
Yeah, most likely it is a congenital bleeding disorder. That is what we are going to derive here. And the next question is, it's okay. It's a congenital disorder. So what I am dealing with exactly? I'm dealing with primary hemostasis and a problem with secondary hemostasis. The primary hemostasis is platelets and von Willebrand factor. Secondary hemostasis is clotting factors. So how to identify this on history and examination? Come on, it's basic MBBS question. I'm not asking anything. If you have a problem with platelets, what kind of bleeds you'll get?
PTK.
Yeah. It's mucocutaneous bleeds. The most common presentation for primary hemostasis defect is mucocutaneous bleeds, like epistaxis, oral bleeds, petechiae, small purpuras can be possible. Mucocutaneous, superficial. If the problem is secondary hemostasis,
Hematrosis.
the deep bleeds. So muscular bleeds, joint bleeds. So that's the main difference. Yeah. So with that, the site and pattern of bleeding may indicate the most likely underlying hemostatic defect. So the commonest bleeding primary hemostasis is mucocutaneous bleeding. And if you have deep bleeding like muscle, soft tissue and joints, it's most likely secondary hemostasis. Even in bruising, the primary hemostasis will be very small and superficial. That's the main difference. They can have bruising, but it will be very small and superficial. And if you have large and deep palpable, mainly palpable bruising, it's mainly indicative of secondary hemostasis defect. Epistaxis is very rare in secondary hemostasis. Gum bleeding is also rare. And bleeding from minor cuts, it's mainly related to primary hemostasis. And bleeding followed by intramuscular injections, it's mostly secondary hemostatic defect. And postoperative bleeding, it's immediate bleeding in primary hemostasis and generally delayed bleeding in secondary hemostasis. Menorrhagia can be seen in both. So based on menorrhagia alone, we cannot differentiate whether it's a primary hemostasis, secondary hemostasis defect. So very few types of von Willebrand disease can have deep bleeds because the associated factor deficiency will be there. So for nutshell, mucocutaneous bleeding is primary hemostasis, deep bleeds are secondary hemostasis defect. If you remember that much, that is enough from this slide. So rarely in hemophilia also we can have mucosal bleeds, very rare. So that like mouth bleeds, dental, post-dental extraction bleeds, epistaxis and gastrointestinal bleeds. Even hematuria is reported. It's very rare, but most likely presentation, most common presentation is deep bleeds. But just doesn't rule out hemophilia after seeing epistaxis and gastrointestinal bleeding. The hemophilia is ruled out because this is a mucocutaneous bleeding. So never rule out. So our child, we taken the history, we got back and taken history. Child had 2 episodes of epistaxis in the last 3 months, but not in any consultation. There's no significant family history, no other bleeding symptoms in the past. So there's no vaccine site hematoma also. So on examination, there's no petechiae, no purpura, no ecchymosis. So this is what our child revealed. So what are the main questions in this child is? So already we discussed this. So can anyone summarize this? First question.
So our child is having
Yeah.
our child is having pathological bleed,
So it's most
mostly
likely
of
pathological bleeding. Second question.
congenital.
Most likely congenital. Third question.
Secondary hemostasis, sir.
Secondary hemostasis. Superman. What kind of bleed child is having?
GI bleed.
Bleed.
Mucocutaneous
So like
bleeds, sir.
epistaxis.
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 Epistaxis,
Yes,
what kind
sir.
of bleeding?
Okay.
Deep bleeding or superficial bleeding?
Mucocutaneous
Cutaneous
bleeding.
So it is defect of primary hemostasis.
Primary.
I'm not complicating anything here. I am talking very superficial. I'm not going to deep also. So don't get confused here. Just remember one point. If it's a mucocutaneous bleed, it is defect of primary hemostasis. If it's a deep bleeds, like muscular bleeds, joint bleeds, it is secondary hemostasis. If you have large bruises on the skin, which is palpable, very likely it is deep bleed. Unpalpable, superficial bruises, mostly mucocutaneous bleed, primary hemostasis. This much is enough for this slide. Don't get confused.
Okay, sir.
So next question is, what are different bleeding disorders you know? Can you people name some few bleeding disorders? Quickly, we have to move on. It's time is around 5:45.
Sir, due to
Hemophilia.
enzyme defect, due to
Classify.
enzyme defect, due to enzyme defect, due to membrane defect, due to platelet defect, due to platelet number and platelet quantity, sir.
Okay, you
Yeah,
still need to
quality
classify. How to classify these bleeding disorders?
So
So
on the
we're talking
basis,
about platelets.
yes, sir.
So you can classify them as like what we discussed previously. So disorders of primary hemostasis and disorders of secondary hemostasis.
Yes, sir.
So disorder of primary hemostasis mainly deals with platelets, and disorders apart from the 1 milligram factors, and disorder of secondary hemostasis we deals with the clotting factor deficiencies. So in that it could be in congenital or acquired causes. So coming to platelet disorders, you can have thrombocytopenia and you have disorders of platelet function. Thrombocytopenia, I'm not going to do deep. It could be decreased platelet survival, it is decreased production, and it increased destruction due to sequestration. So
Yes.
this is the main cause of thrombocytopenia, and disorders of platelet function. The commonest conditions are Langermans and Bernard-Soliers. I'm not going to talk about remaining things. And acquired platelet dysfunction is drugs. There are n number of drugs which can cause platelet dysfunction and thrombocytopenia. And classification of coagulation disorders, we have hemophilia, 1 milligram disease, factor 2, 5, R factor deficiencies, and problems is fibrinogen, dis and hypofibrinogenemia. And the most important, commonly neglected thing is, and problems with antifibrinolysis pathway. So antiplasmin deficiency and plasminogen activated inhibitor deficiency. So these are the other things which can cause coagulation disorders. And acquired conditions like liver disease, DIC, vitamin K deficiency, malignancy related disorders, and if you have coagulation inhibitors after transfusions. So these are the main acquired causes. Inherited, you have any deficiency. Acquired mainly because of liver disease, vitamin K deficiency, and DIC.
So why are you not included RBC problems, sir, due to RBC membrane defect or
RBC membrane defects will not cause bleeding disorders. They will cause anemia. So we are talking about bleeding disorders, coagulation disorders. Coagulation disorders talk about only platelets and clotting factors.
okay.
So these are the list of the drugs. So you have n number of drugs, n number of groups of drugs, which can cause thrombocytopenia, and some may cause even functional platelet function defect. So you can get it easily if you search a drug into thrombocytopenia systematic review. You can get a recent update as well. So the main mechanism is immune mediated suppression of bone marrow. So the both things are, so there is a long list of drugs. So I'm not going to stress on it. So you can go and check. The commonest antibiotics, what you are going to cause is linezolid. So don't forget about linezolid, and antifungals like amphotericin B. These are the two common things which will cause antibiotic induced thrombocytopenia. And even your peptides can cause sometimes, prolonged use of peptides can cause thrombocytopenia. And diuretics like furosemide can cause the thrombocytopenia. So just have a look about this. And anticonvulsants, valproate and phenytoin can cause. So these are the common drugs which were used for long term. I'm not talking about short term uses, but if you're using for long term uses, so when you child have unexplainable thrombocytopenia, have a look about these drugs. So what are the clinical assays you want to do for bleeding disorders, evaluate bleeding disorders? Fast, you have to make a list. Come on.
CBC, PTINR, and the
Okay,
bleeding
so
time,
CBC.
clotting time.
What are you looking for CBC?
What is the current level of hemoglobin reticulocyte count, sir?
Okay.
Platelet count.
So the most
Platelet
important
count, sir.
looking for
Platelet count, sir.
Yeah, platelet count. And in peripheral smear, you need to look for platelet size.
Yes, sir.
Platelet size will tell you some of the differential diagnosis. So CBC done. Next. So whenever I'm asking a question, I think you people need to understand that you need to go through a process of classification. That will be easier rather than picking randomly these things. So what are the how I can classify this question? So answer. So that is what we need to learn first here. So first, I will classify what are the clinical assays which can I do for primary hemostasis. So for primary hemostasis, what I can do, the basic test is CBC to look for platelet count, peripheral smear to look for size of the platelet.
Size.
Okay. Next thing.
Von Willebrand factor.
So you can assess von Willebrand factor defects by what test you're going to order. For von Willebrand factor defects, what test you're going to order?
Distortion test.
Antigen assay. Assay. That's the most first basic test you're going to order. The next thing.
Coagulation profile.
No.
Distortion test, sir.
We are not ending primary hemostasis yet. Yeah, restore setting studies, it's come under a group of what investigation. It's not simply restore setting test. There are a lot of other tests like similar tests which you have to combine. Basically, what you're doing for restore setting, what you are detecting there?
Platelet aggregation defects.
Yeah. So you have to
Factor VIII test.
yeah, we have to combine them as platelet function assay or platelet aggregation assay. So if you have normal platelet count also, you can have epistaxis and petechia. You need to think of platelet functional disorders. So there you need to have platelet aggregometry. So don't forget simple investigation of bleeding time. So bleeding time is a global test for primary hemostasis. So this is a bedside test. If you don't have other tests also, if you perform this bleeding test, it's very useful test. You should know how to perform it. I recommend everyone who is listening this class should perform a bleeding test. I should know how to perform bleeding test, bleeding time. So the global tests are bleeding time, and if you have machines like this and you have a setup like this where have a PFA, platelet functional assay 100 and thromboelastography, it's fine. But if you don't have also, don't worry, you do just bleeding test. And platelet aggregation studies not available commonly. You need to send to very hi-fi centers like CMC Vellore, and routinely not done in any lab, even high labs like Lalpath, Vimta, even they are not doing this. So the most common center which is performing the studies in South India is CMC Vellore. And the other alternative for this platelet aggregation studies is you can look for platelet surface glycoproteins, and this you can done in any common lab, any routine lab like Lalpath and Vimta. So what you are sending is you're asking for flow cytometric analysis of some glycoprotein surface glycoprotein. If you ask for CD41A and CD61, if it is deficient, it is globulin thrombasthenia. And you ask for CD42B and A, if it is deficient, it is Bernard-Soliers. These are the two common things what you are going to look for in the platelet functional disorders. So you can ask this. Up to this, you can finish your basic investigation if you're suspecting platelet functional disorder. If you're not able to find out GT and BSS, you need to refer the child for a center where they can perform all aggregation studies. And what routinely we can perform is von Willebrand antigen assay. So rest of the analysis is not done in any routine lab. You need to send to higher lab again to CMC Vellore. So the first one, von Willebrand antigen assay you can do. If antigen assay is low, then you need to find out what type of von Willebrand disease, type 1, type 2, type 3. For that, you need to refer them for higher centers. So this is the basic investigations you can do for evaluating primary hemostasis. So sometimes we are encountering pseudothrombocytopenia. Pseudothrombocytopenia is nothing but your automated machine will give low platelet count. But if you do manually, the peripheral smear, you can get a normal platelet count. So what could be the reasons for this? One thing is if you are sending in EDTA and you have an IgG and IgM platelet antibody, it can cause a clumping. And if you have platelet cold agglutinin, sometimes you can have this. And unexpected large platelet size like in ITP, you can have spuriously low platelet count because it will not consider that as a platelet. And many times if you have sent a partially clotted sample, it will result in platelet clumping. So it causes conjunctive thrombocytopenia. So be careful when you're confirming thrombocytopenia. You need to rule it through the pseudothrombocytopenia. Always confirm low platelet count manually. That is the first thing you need to learn about when confirming thrombocytopenia. So always check your manual platelet count, not the machine count. Machine count sometimes unreliable. So always try to get a peripheral smear to look for confirming thrombocytopenia. Never judge low platelet count on a machine given value. So bleeding time, it's very screening test for interaction between platelets and bleeding blood vessel wall. The commonest method is IV method, but it's very painful for the child. So we are not going to do that thing. So here you need to inflate the BP cuff to 40 mm of Hg, and you need to make an incision of 10 mm long and 1 mm deep in the volar aspect of forearm. So this is the template method, which is standardized now. So previously, like nicks are not advisable now. This is the IV method. It's the template method now. And the one which easily we can do is Duke's method. You can just give a stab incision with a blood lancet on a finger or earlobe. Earlobe is the recommended site. And normal bleeding time is Duke's is less than 3 minutes and IV is less than 8 minutes. If anything is prolonged, like more than 5 minutes in Duke's method and more than 10 minutes in IV method, it's a concerning of coagulopathy. There's a problem with primary hemostasis. It could be von Willebrand disease or it could be platelet disorders. And many developed countries, they are obsolete because it's a frightening procedure, and it is influenced by variable like your skin thickness, temperature of the skin, and application of the method. Sometimes I can give incision more deeper. Sometimes I thought a child will be afraid, so I'll give incision very superficially. So this is subjective thing. So with this, it is not standardized. Sometimes we will not able to identify the problem. But if you do it correctly, at least 1 mm deep incision. So many times you can identify this problems with primary hemostasis. So practice it, bleeding time, and encourage if any do bleeding time in any bleeding disorder, suspect bleeding disorder child. And this is a diagnostic organ of platelet disorders. You do CBC in peripheral smear. If you found thrombocytopenia, get the size of the platelet, and based on that, you can identify what is the cause. So small platelets are commonly seen in Miscart-Albright syndrome and X-linked thrombocytopenia, and large platelets are commonly seen in Bernard-Solier syndrome and gray platelet syndrome. So these are the common things where the platelet cells will be abnormal, and sometimes ITP can also have large platelets. And if you have platelet aggregation assay, that is then you can identify easily the different types of platelet disorders. So I'm not going to go deep into it. So coming to secondary hemostasis assays, what are the common tests you order for secondary hemostasis?
PT, APTT, INR, sir.
Yeah. Anything else?
Mixed studies.
Prothrombin time and APTT, the last thing is common pathway. So prothrombin time is for which pathway?
Extensive.
Extensive.
For extensive pathway. So any problem with factor 7, it is identified easily, but it can also identify common pathway defects. So don't forget that unless you have a common pathway, your blood will not clot. So it's not alone factor 7 deficiency, even common pathway defects can prolong prothrombin time. And APTT is mainly for intrinsic pathway defects, and even it can assess common pathway. So because the final the clot should happen in both the tests. In thrombin time, it's mainly the function of fibrinogen. And if you have any abnormality in this test, you need to do the mixing studies. So what mixing studies tells is whether it is the deficiency of the factor or it is some inhibitors which is blocking the factors. So in mixing studies, what they do is they mix with the normal plasma. After mixing with normal plasma, if your PT, APTT is getting corrected, what it means?
Factor deficiency, sir.
So it is factor deficiency. If it's not getting corrected,
Inhibitors are present.
Inhibitors.
so there is an inhibitor. So that's all. They're not going to tell what factor deficiency. So mixing studies is mainly to look for whether it's a factor deficiency or inhibitor is there. Once you found that is a factor deficiency, then you need to do for specific factor assays. So based on what is the prolongation, whether the prolongation with the prothrombin time, prolongation with the APTT, prolongation with the thrombin time, you need to send the factor assay. So if you have prolongation of APTT, what factor are you going to send?
8 to
You have
9.
isolated
8,
prolongation.
9, 11, 12.
Most commonly it's 8, 9. 11, 12 is very rare. So sometimes 12 we can cause some delayed bleeding, but 8, 9 you have to remember. So if you have prolonged APTT and still had significant bleeding, you are dealing with factor 8 and factor 9. So if you have prolonged PT and you are dealing with factor 7. So that's what you need to think in your mind. And for factor 13, you have urea clottage test, it's easily done. So all these tests are easily done in any lab, any standard lab. So no need to worry about second hemostasis. The only problem for getting test done is the primary hemostasis. Plate aggregometry is not done in any standard lab. So for that, we have that flow cytometry as a remedy. So see here, so APTT starts with intrinsic pathway. It can evaluate common pathway as well. PT starts with extrinsic pathway. It can evaluate common pathway as well. But thrombin time mainly evaluate the conversion of this fibrin to fibrinogen and clot formation. So these are the 3 common tests we can order when you're suspecting secondary hemostasis. So to summarize this, any child with bleeding symptoms, you need to ask history. There's no replacement for history. You cannot, should not order any test without taking standard history and bleeding questionnaire and family history and physical examination. And the simple basic test you are going to ask is CBC, BT, CT, include that in that thing, and PT, APTT. So these are the basic initial laboratory tests. You cannot order 1 milligram assay in the straightforward. So you need to order only these 3 for initially. So CBC to look for platelet count, CT, BT, and PT, APTT to look for secondary hemostasis assay. So now you found there is low platelet count. So you found that the platelet count is low. So then you need to approach what are the causes of platelet count. So the most important thing is you need to confirm it by peripheral smear. Never ever skip this point. Your machine shown platelet count is low, but you need to confirm it with peripheral blood smear. Then you need to look for the causes of thrombocytopenia. So I'm not going to deal with it. And if you have abnormal PT or APTT or both, then you need to do mixing study. Don't bypass this step. You need to go for mixing study. And if you have correction with mixing study, then you're dealing with factor deficiencies. And there is no correction, it is inhibitors. You need to assay, you need to go for lupus anticoagulant to look for other specific inhibitors. This entirely different thing, and you are not going to deal with that. But if you have all normals, you have normal platelet count, if you have normal PD, APTT, and if you have normal this thing, PT and APTT, and normal clotting time. So what are the things you need to consider here? When you have normal platelet count, normal PD, normal APTT, what you have to think of?
Hypertension, sir.
Hypertension, okay, which is very rare in children. Yeah, we are thinking of non-hemostatic causes. Good, you have to think of non-hemostatic causes. Apart from non-hemostatic causes, hypertension, what are the things you can suspect which can cause bleeding? So you need to think of vascular malformation. That is what I told previously. So whenever you before ruling out bleeding disorders, you need to rule out anatomical causes. So other close mimicker is vitamin C deficiency. Vitamin C deficiency can also present as hematorosis. So never forget about when evaluating hematorosis, you need to look for vitamin C deficiency as well. And what we are not assessing here. So by sending platelet count, PTINR, APTT, we are assessing only few conditions. So what all conditions we are not assessing here, because we previously discussed so many bleeding disorders. So in that I need to pick up what I am not assessing here. So what you're not assessing here by sending CBC, PT, and APTT, So you cannot detect factor 13 deficiency. You cannot detect fibrinogen defects. So you cannot detect 1 milligram defects. You cannot detect platelet function disorders. So these are the 4 common things you need to consider when you have normal platelet count, APT, but child has significant bleeding. So factor 13, fibrinogen defects, 1 milligram defects, platelet function disorders. So always think of these 4 conditions when you have all normal initial workup. So for this, what you are going to send now? When you have normal PT, APTT, and platelet count, what are the assays you have to do now? Come on, man, read, man. Just I already marked them. For
Then
reading also,
we
you
assess
people are
platelet function
very
disorder.
sad for me to take this class. Already we discussed it. For factor 13, you are going to do urea claudilysis assay. For fibrinogen, you are going to do thrombin time. For 1 milligram, you are going to do antigen assay. For platelet function disorders, you cannot do platelet aggregometry, so we are going to send flow cytometry. I think I should stop this class. I feel I hardly feel I don't see any encouragement from you people.
No,
So
sir.
this is a time waste course for me. I feel I am taking so much time and trying to make these PPTs and to present here and taking this much time on a busy schedule, but I'm not getting that much encouragement from you people. I think I'll switch over to monthly CBDs, and I think we can wean it off to 2 monthlies and 3 monthlies because there's not much encouragement and much interaction. And without interaction, it is very difficult for us to take classes. Okay, we'll move on. So this is our child. So our child has persistent nasal bleeding, and there's a PRB. We given massive transfer protocols, PRB, CFRPs, and ENT opinion taken. They examined the nose. There's no local pathology. There's diffuse oozing from the nose, and the child was managed conservatively, and they asked us to do bleeding disorder. So these are the investigations we did, and they came normal, completely like platelet count was normal and PD was normal. So for HP is dropping. So what it is, what we kept already discussed. Further workup, what we did is, so we did urea claudilysis test, which is normal, and thrombin time, which is normal. So what investigations you want to plan now? So we have done PD, APT, which is normal, and platelet count was normal. And urea claudilysis test to factor 13 is normal, thrombin time for 5 is normal.
1 milligram antigen.
So straight away 1 milligram. Anything else before that? So I stressed that in the previous thing. So it's a global test for primary hemostasis.
Bleeding time, sir. Look for bleeding time.
Never
Bleeding time.
Bleeding time. That's what the one point you need to learn from this class is the basic test for even a bedside test for in peripheral clinic is bleeding time. So do it properly and assess it properly. And if you have prolonged bleeding time, you need to refer the child for further evaluation. Or you can give one platelet transfusion also if you're thinking that thing. So finally, because we stopped doing bleeding time in the previous, because we thought it's obsolete now, and we have a lot of study, new tests arrived. But I'm telling, in developing countries like India, you cannot replace bleeding time. You cannot get a PFA 100, and you cannot get a thromboelastography, which is very for high-fi medical hospitals, but it's not for the basic hospitals. So always make a habit of doing bleeding time by yourself. Don't trust any lab person. Make a habit of doing it yourself. So what do you want to do now? So BT was severely prolonged. So what is the pending investigations now? What you have to DDs now? What is your DDs now with the prolonged bleeding time?
So platelet functional disorders, sir. Any aggregation or adhesion
Platelet function
disorders.
disorders, and second thing is previously someone answered now. We were going to do
1 milligram factor deficiency.
so these are the 2 common things you have to do work up now. So what is platelet function disorder and 1 milligram assay. So what investigation you want to send now?
1 milligram factor antigen assay.
So 1 milligram antigen assay, and for platelet functional disorders, what investigation you have to do now?
So CD41 And
No,
your
sir.
Lipoproteins.
Do flow cytometry based on CD41, CD61, and CD42. So that is what you need to do. And we did the thing, and we found that there is no expression of CD41 and CD61. So it was consistent with glandular thrombasthenia. So this is a platelet functional disorder. So we given multiple RDPs and SDPs, and in 24 hours the bleeding was completely controlled. See what is the difference here. So if you identify the pathology, the treatment is very easier. So someone can question me. So if we don't have facilities for platelet functional assay also, flow cytometry also, how to control bleeding in this child? So you need to just to follow massive transfusion protocol. What is that massive transfusion protocol? Can anyone summarize that? I don't want theory, bleeding total blood volume in 24 hours, 50% in 3 hours. I don't need. What is the recommendation for massive transfusion protocol?
So 1:1:1.
What is 1:1:1? What you are going to do 1:1:1?
PRBC, FFP, and platelets, sir.
That's all. So
To
if you
avoid
have massive
cancer
bleeding, definitely you are going to give FFP. By giving FFP, what you are ruling out? What you are treating?
Factors we are giving.
Factor deficiency. Most important thing is not only factor. By giving FFP, you are replacing some particle which is related to primary hemostasis.
Calcium.
One will
Primary hemostasis. I am not
One-
asking secondary hemostasis. 1 milligram factor.
Different factor.
So by giving FFP, already you are treating 1 milligram factor here. And in this child, particular child, if you see, already we given FFP as a massive transfusion protocol, but still bleeding is not controlled. So you are almost ruling out 1 milligram factor in this child. If people understand what I am telling.
Yes, sir.
And in this child, what not given is platelets. So highlightly, we are suspecting platelet functional disorder in this child at this step. So once the massive transfusion protocol is going on, automatically the third thing is platelets. First thing is PRBC to replace the blood. Second thing is FFP to replace the coagulation factors and 1 milligram factor. And the last thing is pending is platelets. So whatever may be the underlying disorder, you no need to worry about. But if you follow massive transfusion protocol, you can control the bleeding. That's the simple stuff I can tell for anyone who is dealing with a massive transfusion but couldn't able to do the test to get the diagnosis. You don't worry about the diagnosis. Diagnosis you can get later on. At this particular moment, it is about saving a life. So you need to worry about saving the life, not about the diagnosis. Don't delay transfusions of platelets and FFP for the sake of getting a diagnosis. That is second thing. So in any emergency, you don't worry about diagnosis. You give all the platelet blood products and get and save the child. And even in this child, we delayed it by 24 hours. So this should not happen. So any child coming to shock, needing transfusions, and if you're just committing for a massive transfusion protocol, just keep dumping all things. And later on, you can get the diagnosis. Once the child improves from that and bleeding stops, you can get a diagnosis. But what I'm telling is don't delay your transfusions for getting a sake of diagnosis. If a child coming to mild bleeds, then you can get a diagnosis. But for major bleeds and life-threatening bleeds, don't worry about diagnosis, dump them with the platelet products. Same 1:1:1. If you want to give 10 ml per kg PRBC, give 10 ml per kg FFP, 10 ml per kg platelets. The same order. For adults, you give 1 unit, 1 unit, 1 unit. So in that order, you need to make the volume should be same. So 100 ml PRBC, 100 ml FFP, 100 ml platelets. So like that, you need to match them. So roughly 10 ml per kg, 10 ml per kg, 10 ml per kg. So say simple for pediatrics, you follow that 10 ml per kg, 10 ml per kg. In others, they'll have units. I'm going to show that massive transfusion protocol for adults, how they will do that. So other measures, what you can do is don't forget about local measures. So simply pinching the nose, nasal packing. So if you have a local injection site bleeding, so compressing that, that's a very important measures. Apart from that, antifibrotic things like tranexamic acid, So just keep giving mucus transfusion platelet product. Even without diagnosis, you can do platelet transfusions, even normal platelet. Even with you have normal platelet count, I'm telling. Even with normal platelet count, you can try platelet transfusions because you can suspect functional disorders. And finally, you can give recombinant factor 7A, which is very, it's very refractory to platelet transfusions also. So this is the last resort. Recombinant factor 7 is the last resort. It's available. You have to procure it. So this is the main thing you can do for nasal packing. For posterior nasal packing, you need to insert a Foley's cutter and insert the bulb. And for anterior nasal packing, you can use this. Apart from the gauze piece, what is routinely available is easily available now. This is a Medocell. So it is a hygroscopic one. So it will be like this initially. Once you put it to the nose, it will swell up, and it will compress the bleeding site. So you can easily practice in the local, even in the secondary and the primary centers. And this is what FFP contains. FFP contains 1 unit of factor per ml for all factors. So if you don't know the diagnosis, then you can straight over give FFP. Don't give cryoprecipitate. If you don't know what is the diagnosis of secondary hemostasis, the choice is FFP. And if you know I am dealing with 1 milligram factor disease, then you can go for cryoprecipitate because you can decrease the volume. And you think I am dealing with factor 13 deficiency, go for cryoprecipitate. And if you have confirmed fibrinogen defects, then you go for cryoprecipitate. So only these are 3 indications for cryoprecipitate. And if you have hemophilia, confirmed hemophilia, and you don't have a factor with you, then you can give cryoprecipitate. For rest of all indication, if you don't know the diagnosis, just to give FFP, don't go for cryoprecipitate. And this is the thing, recommendations for your hemophilia. The main thing is you need to maintain certain levels. So how to do the calculations? So the recommended dose of factor is what is the desired rise in plasma factor 8 and into body weight into 0.5. Why it is 0.5? Because so 1 unit of factor, recombinant factor will rise the plasma factor by 2%. So for example, you want to achieve a 60 units per DL in a 20 kg child. So you need to achieve plasma level of 60 units per DL. So for that, you need to multiply 60 into 20 into 0.5, that is 600 units. So these 600 units you need to give. So the half-life for this plasma factor is, recombinant factor is 8 to 12 hours. So you need to keep repeating this every 12th hourly in life-threatening bleeds like IC bleed. So for IC bleed, you want to maintain, see here, example, for IC bleed, so you need to maintain the factor above 100 units per DL for 24 hours. So that is what the standard practice is. So initial 24 hours, you need to maintain it above 100 units. And next 5 days, you need to maintain it about 50 units. So you need to calculate, depending on the weight of the child, you need to calculate how much I have to give. So, and you need to give it 12th hourly. For IC bleed, you need to replace 12th hourly, but ideal recommendation, you need to give continuous infusion. So this is what pediatric massive transfusion protocol. See here, depending on the weight of the child and the blood volume, this is what they recommended. So initially in emergency, you get the PRBC. And in the second, in the B, you need to add FFP and platelet. So for 1 RBC, 1 FFP, you need to add 3 platelet. I'm not talking about SDP, I'm talking about RDPs here. And in C, you need to add cryo. So you need to keep repeating this BC till the bleeding stops. Initially for resuscitation, start with only PRBC. And to control, if bleeding is ongoing and you're giving landed up in massive transfusion protocol. And B, you need to give FFP and platelets also. In C, instead of platelets, you replace with cryo. And you keep repeating BC, 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 BC till the bleeding stops. You keep on repeating BC. So how much time, I am not going to tell you. If the child is bleeding profusely and you are going to resuscitate the child with PRBC, you can give it faster. If child is bleeding slowly and giving PRBC slowly, you can do same thing slowly. But simultaneously, you keep giving RBC, FFP and platelets simultaneously. You don't delay PRBC transfusion for FFP transfusion. Don't delay FFP transfusion because child is already hypovolemic and child is losing so much blood volume. Don't delay the transfusions. The most common mistake if people do is you give PRBC first. It is going to take 2 to 3 hours. Then you start FFP. It's going to take another 2 hours. Then you start platelets. It's going to take another 1 hour. By the time 6 hours, child is going to be profusely and child is going to land up in again shock. Again, you're going to resuscitate the child. So the massive transit protocol is you need to administer them simultaneously. You need to pump them. So don't delay them. Don't delay. I'm going to give blood now, and then I give FFP. Then I'm going to give platelets. So there's no delay in this. You should dump them simultaneously. So the main objective here is to stop the bleeding at the earliest. So take home messages. So administer bleeding questionnaire. I think everyone should keep the bleeding questionnaire in your OPDs, and if you have any bleeding symptoms in any child, you need to screen them all. And you have detailed history and examination to be taken, and if you suspect pathological bleeding, and you should do basic coagulation workup, include bleeding time. Don't forget bleeding time in basic coagulation workup. And what the lab people are going to do is very cumbersome method of BT, and I think it's advisable if you suspect strongly bleeding disorder, please do bleeding time by yourself. At least do Duke's method. And initiate definitive therapy if indicated in critically ill patient without waiting for diagnostic results. So never delay treatment for diagnosis. You can easily diagnose it later on. And don't forget BT as a screening test. Thank you.